All right, this is a case where the patient had catastrophic failure of his fixed partial denture or a traditional bridge, retained on natural teeth, both teeth fractured at the gum line. So our first objective is to remove the teeth atraumatically, keeping all the bone intact and also importantly keeping the gingiva intact. So we don't flap the soft tissue at all, but instead we trough the mesial and distal of the remaining roots and then use a luxator to gently luxate, staying off of the facial and the palatal to preserve that thin, fragile bone. See here we're luxating. We'll then, after we get some mobility, move to a 4-step with apical grip. I prefer to use a twisting motion to remove the teeth so we don't put pressure on the buccal bone. This tooth came out relatively easily. The other tooth was endodontically treated. After tooth removal, of course, we always want to make sure that we curette any remaining granulation tissue, get the socket nice and clean on hard bleeding bone, and we check that by the feel, when we can feel it scraping on the hard bone, the tactile feedback. We're now using an implant probe to measure the depth of the socket and to see the trajectory of where that root was. Typically the roots are very much to the facial, so on immediate placement we're often trying to go more to the palatal. Okay, now we're working on the endodontically treated tooth. We'll also trough on the mesial here. The patient has, in site number 12, another implant crown, so we actually want to stay away from that to preserve the soft tissue around that implant. So in this case, we'll try to luxate here, but on this canine we're really not getting much movement. So what we'll do instead is use our high-speed handpiece, a rear venting surgical handpiece, to drill down the canal of the root. So we'll make a purchase and follow the gutta percha to try to stay in the center of the root. And then we'll check, make sure that we're staying on target, that we're not getting off track to the buccal or to the palatal or mesial or distally towards other structures. So once we've verified that, we'll continue to cut our slot. And it's especially important, again, to stay off the buccal. Make sure that we don't cut through that thin buccal bundle bone. Once that slot is cut, we'll stick our luxator in there and separate the roots. We've removed half the root here and then elevated the other half of the root into the space, and then we can extract it easily. After the extraction, again, we'll use our curette. I like to use a Molt 2-4 on anteriors to get down there and clean out any granulation tissue. And then we'll take the implant probe again and check. We're checking to make sure that all the walls are intact in the socket, and also to visualize the trajectory of where the root was. From our CBCT, we know that we want to be more palatal. Now we're flushing with sterile saline. Just make sure that we have both sockets completely clean before continuing on. So once we have our sockets clean, we'll go ahead and create our osteotomies. In this case, I have my Lance pilot drill. Due to the depth of the sockets, that's going to be an inadequate length by itself, so I'm putting a drill extender on so that I can go to length without hitting the handpiece on the adjacent teeth. So my trajectory here is to create a purchase that's more palatal than the socket. You can see I dropped into the bottom of the socket and then I moved palatally to create my purchase point. So we're drilling that. You can see in this photo that the socket that we've created is lingual to where the tooth root was. If we just try to go down where the root was, most likely we'll fenestrate out to the buccal. So here again demonstrating on the palatal aspect. We've now moved up to the 2-0 drill. And then we'll just check again with our implant probe to verify that we're in good solid bone, and to check our trajectory one more time. Now we're sizing up to our osteotomy to the implant size. See, we're using larger osteotomy drill here. And again, you can see that the osteotomy is palatal to where the root was. That keeps us in good bone, away from the buccal wall. We don't, in these immediate cases, we don't want to engage the buccal bone at all. Okay, and then we're going to repeat the same thing in the other socket. Again, a palatal purchase. Okay, so then I'll size up with my 2-0 drill, and once I've done that, again checking with my implant probe to assure that I haven't fenestrated. And here I'm placing my opposite index finger against the bone to visualize the contour, because the maxilla often dives back quite a bit, and it's easy to fenestrate the apical portion if you're not watching that. Here are my 2 implant probes in place, just to show that the maxilla does have that flare. As much as we try to parallel them anatomically, it's not possible sometimes to do that without running into neighboring roots or implants. So again, checking the osteotomy here to verify that we are engaged into the palatal bone and that we're not going to fenestrate. The one big disadvantage of not flapping, although it's a much improved healing and outcome, is that the visualization is more difficult. Okay, now we're visualizing our trajectory one more time here in site number 7. And on these anterior cases, I like to use a hand driver because it gives me good tactile feedback on the bone density. It also really helps me visualize my trajectory. So we'll go ahead and take the implant, pick it up on the driver. Very important here to not touch anything with the sterile implant. So we'll pull it out of the driver and then place it into our osteotomy. I'm going to exaggerate the angle to assure that I go into my osteotomy and not into the socket. And then after I put a couple threads in, I'll go ahead and advance. Now our implant is in place. You can see here I haven't placed it as deep as the final placement, because once the implant is in, backing it out, if you go too deep, you'll lose stability. So I'll approach my final and I'll wait and take an x-ray before I actually sink it all the way to the final depth. Again, here we're engaging into the palatal bone and we're slowly advancing, watching our trajectory as we advance the implant into place. Here you can see both implants are placed, and then we're slowly working them down to the appropriate depth. In the anterior, with a deep conical connection implant such as this, we do want to be quite a ways subcrestal, 3 to 4 millimeters, to give us plenty of room for a nice gingival emergence. And again, you can see our trajectories here. There is some maxillary flare, but as close to parallel as possible. So after checking that, we'll go ahead and take a couple of PA radiographs to confirm our location and placement. You see this case is pretty tight, but we ended up fairly parallel. And here I'm just, now that I have the radiographic confirmation, placing those implants all the way to depth. And the timing is also important on the implants. You see the little dot on the driver, that coincides with the flat hex of the internal component of the implant. So I want to make sure that that timing is correct, because in tight cases that does matter. Here I'm now putting the torque wrench on, and I'm checking my torque to assure that I have enough primary stability to go ahead and place healing abutments instead of cover screws. And on that first implant it looked like I had about 40 newton centimeters of torque or so, and this one even a little more, 45 or 50. So plenty of torque to go ahead and place healing abutments. One thing I like to do in these cases is graft the gap on the buccal. So before I do that, I'll try in my healing abutments. I like to use an anatomically shaped healing abutment to develop from day one a nice emergence profile. So we'll try sometimes a couple different heights in to get exactly the right height to nail that emergence profile, taking a little extra time. And this step saves a lot of time 3 or 4 months down the road after healing, when we're trying to create the final restoration. So now that we have that figured out, I'm going to take some Osteogen. This is a calcium apatite product embedded in a collagen plug, and we'll take it and compress it into the defect on the buccal to graft that gap. And this does a couple things. It helps maintain the tissue. The research shows that grafting reduces dramatically the amount of resorption we'll have. It also creates a nice seal to keep debris and bacteria out of the site as it's healing. So we'll place that down in, and then I'll use a curette of some type to compress that further into place. Once we do that, we'll use the healing abutment to hold the graft material. So we've now secured the healing abutment, which is holding that compressed Osteogen product in place. Again, I'm using the curette here to make sure that it's completely compressed. And grafting on the palatal of the maxilla is not as mission critical because of the thick tissue. It always seems to heal in well, but we do try to graft all the way around the healing abutment regardless, just to keep debris out and improve chances of good healing. So you can see here with the graft placed on the buccal before we've adapted, and then after the healing abutment is in there holding it in place. And here we have both implants completed with the graft and the healing abutments. And then I always like to give a little bit of dexamethasone on these implant cases. This limits the amount of post-op pain that the patient has because it will reduce the amount of swelling. And then this is a post-op about a week later. You can see how quickly and how nicely the tissue heals in around that calcium appetite product. All right, thanks for watching. I hope you enjoyed.